Welcome to everyone joining us from Doc Vatz's YouTube channel for this focused exploration.
And hello to our regular listeners of The Deep Dive. Welcome back.
Today, we're diving deep into, a really significant challenge in general practice, fibromyalgia.
Absolutely. And our goal today really is to give you, the GP listening, a very practical, evidence-based handle on fibromyalgia.
Yeah,
We've drawn on key UK resources, things like NICE-CKS, other major guidelines, to kind of distill what's most important for your day-to-day work.
exactly. The aim is to cut through some of that complexity that often surrounds fibromyalgia. We want to offer a clear path for you towards, recognition, diagnosis, and importantly, effective management.
Which ultimately benefits both you in your busy practice and, of course, your patients.
Definitely.
So in this deep dive, we'll be looking at the core features, the prevalence here in the UK, and specifically in Scotland, too, where we see those links with socioeconomic factors.
Right.
We'll also unpack the modern understanding of what's actually going on physiologically, how you can diagnose it confidently, and importantly, practical management strategies you can, hopefully use straight away.
Okay, fantastic. Let's get right to the heart of it then. Understanding fibromyalgia itself, what's the sort of core definition we should be working with?
So fundamentally, it's a chronic condition. Key features are widespread musculoskeletal pain, significant fatigue, and then a whole constellation of other symptoms affecting different systems, mood as well.
Right.
But the really crucial bit, the key shift in understanding for us now, is that it's classified as a nociplastic pain condition.
Nociplastic. Okay, can you break that down a bit for us? What does that mean in practice?
Yeah, think of it like this. The pain isn't primarily coming from, say, damaged tissue or inflammation out in the body. Instead, the problem lies in how the central nervous system, the brain and spinal cord, processes pain signals.
Ah, okay, so it's about the processing.
Exactly. It's an issue with the body's pain regulation system itself. And, understanding that is fundamental. It lets us move away from just endlessly searching for other causes.
The ruling out game.
Precisely. Towards positively identifying fibromyalgia based on its characteristic features. It allows us to actually rule in the diagnosis.
That feels like a really significant shift in approach. So why is this nociplastic understanding so critical specifically for us in primary care?
Well, a few key reasons. First, it's common, really
Yeah.
common. UK prevalence is estimated, 2 to 4%,
Right.
maybe higher.
Right.
So you're definitely seeing these patients. And second, unfortunately, many people go undiagnosed for years, which leads to immense frustration and often cycles of unnecessary tests and appointments.
Yeah, I can imagine that sounds incredibly difficult for the patient and, frankly, a strain on GP time and resources, too.
It is. And that's exactly where primary care is so vital. You're perfectly placed for that early recognition and providing the long-term support these patients need. And interestingly, getting that diagnosis right and relatively early can actually help streamline things later on. It can reduce that burden of excessive testing and maybe unnecessary referrals.
Okay, let's dig into those numbers a bit more then. The epidemiology. What does the data tell us? Who's most affected?
So that UK figure, 2–4%. A very striking feature is the gender difference. Women are diagnosed much more often, maybe a 9-to-1 ratio, typically between 30 and 60.
9-to-1. Wow.
Yeah. But importantly, we're getting better at recognizing it in men and older adults too, which is good.
And what about the picture in Scotland specifically? Is it broadly similar?
Broadly, yes. The available data aligns with the UK figures, but, and this is important, data from sources like the Scottish Public Health Observatory points towards a higher prevalence of chronic pain and related issues, including fibromyalgia, in areas of socioeconomic deprivation.
Right. That's a really crucial context for GPs in Scotland.
Absolutely.
Right.
Considering those wider social determinants is particularly relevant there.
And you mentioned the impact on GP workload earlier. Is there data on consultation rates?
Yes, definitely. Studies consistently show people with fibromyalgia consult their GP much more frequently. Some research suggests up to 3 times more often than patients without the condition.
3 times?
Yeah, which really highlights the impact on your time, resources, and links back to those higher rates of testing and referrals we talked about.
Okay. So common, significant impact, some regional variations. Let's get into the why now. What's the current thinking on the pathophysiology? What's actually happening in the body?
Right. As we touched on, the core idea is this disorder of central pain processing. The pain signals aren't necessarily driven by ongoing damage out in the periphery, but by how the central nervous system interprets and modulates those signals. Altered nociception is the term.
Okay. And what are the key mechanisms driving that altered processing?
There are several key players. First, there's central sensitization. You can think of it like the nervous system's volume control getting turned up too high,
Mm.
so normal sensations might get interpreted as painful.
Okay, hypersensitivity.
Exactly. Then secondly, there's often reduced descending inhibition. Our brain has pathways to naturally dampen down pain signals, but these seem less effective in fibromyalgia.
Right, the brakes aren't working as well.
Kind of, yeah. We also see autonomic nervous system dysregulation. That imbalance can contribute to things like fatigue, the gut symptoms that link with IBS.
Interesting. What else is going on biologically?
Well, there are often neurotransmitter imbalances.
Hmm.
Tend to see lower levels of things like serotonin, dopamine, or adrenaline, all important for mood, sleep, pain control.
Hmm.
And conversely, higher levels of substance P, which transmits pain signals. And finally, there's growing evidence for neuroinflammation, low-grade inflammation within the central nervous system involving activation of glial cells.
So it's definitely not all in the head in that old dismissive sense. Is there objective proof of this neurological basis?
Absolutely. Functional MRI scans, fMRI studies show differences. They show increased activity in pain processing areas of the brain
Yeah,
in people with fibromyalgia, even in response to non-painful stimuli. It confirms the pain is real, it's neurologically mediated.
that's really important validation. And what sort of factors might predispose someone or trigger fibromyalgia?
It seems to be multifactorial, really. There's likely a genetic component it can run in families sometimes. Psychosocial factors are definitely important things like chronic stress, past trauma, adverse childhood experiences, underlying mood disorders.
Hmm.
Environmental triggers can play a role too, like certain infections, or sometimes a physical injury seems to set it off. And sleep disturbance is a big one. It's both a symptom and likely a contributing factor, creating a bit of a vicious cycle with pain and fatigue.
Okay, that paints a clearer picture of the underlying complexity. So how does all this manifest? When a patient walks into your consulting room, what are the key clinical features that should make you think, could this be fibromyalgia?
Well, it often presents as this collection of symptoms, and they can fluctuate quite a bit, which is one reason diagnosis can sometimes be delayed. But there are three core symptoms that should really put it on your radar.
Okay, the core three.
Yes. First,
Yeah.
widespread pain. Has to be persistent, lasting more than 3 months, and widespread means affecting both sides of the body and both above and below the waist, often described as aching, burning, sometimes stabbing.
Right, widespread and persistent. What's number two?
Significant fatigue. This isn't just ordinary tiredness. It's
Oh.
often described as overwhelming, not feeling refreshed even after sleep, and it really impacts their ability to function day to day.
Okay. And the third?
Cognitive dysfunction. Patients often call it fibro fog. Difficulty concentrating, problems with memory, just feeling mentally sluggish or unclear.
So it's much more than just pain. That fatigue and fibrofog sound really central.
They absolutely are. And alongside those core three, sleep disturbance is incredibly common and tends to worsen everything else.
Hmm.
Then there's a whole host of associated symptoms you frequently see.
Such as, what else should we be looking out for?
Well, persistent sleep issues are very common. Difficulty falling asleep, staying asleep, waking up feeling unrefreshed. Mood symptoms. Depression is common, maybe 40–60% of patients. Anxiety, maybe 30–50%.
High rates.
Very. Lots of somatic symptoms, too. Things like irritable bowel syndrome, tension headaches, pelvic pain or frequent comorbidities, neurological type symptoms like pins and needles that aren't in a specific nerve pattern, dizziness, restless legs,
Hmm.
increased sensitivity is another one, sensitivity to noise, light, smells, sometimes even temperature. Reflects that central sensitization again. And understandably, all of this often leads to significant functional limitations affecting work, social life, daily activities.
You mentioned a UK study from 2019. What did that show about how common these are?
Yeah, that was quite revealing. It looked at over 1,000 primary care patients diagnosed with fibromyalgia, found really high rates, 94% reported poor sleep, 91% significant fatigue, 78% cognitive issues. Really underscores the burden.
Wow, those numbers are stark. Are there any practical assessment tools GPs can use in clinic to help quantify these?
Yes, definitely. There are a few simple ones. The Widespread Pain Index, or WPI, basically counts the number of body regions where the patient has felt pain recently, score from 0 to 19.
Okay.
Then the Symptom Severity Scale, SS, assesses the severity of fatigue, unrefreshed sleep, and cognitive symptom score from 0 to 12.
Right. WPI and SSS?
Exactly. And there's also the Fibromyalgia Impact Questionnaire, the FIQ, It's a bit more detailed, looks at functional status, but can be really useful for tracking how things are changing over time.
Those sound manageable. Any sort of clinical pearls for spotting these signs? Things to specifically ask about?
Yes, definitely ask actively about the pain distribution check. It's truly widespread. And specifically ask about fatigue and cognitive fog, because patients might just say they're tired or a bit forgetful and might not volunteer the extent of it unless prompted. And always remember, symptoms fluctuate. Ask about factors that might make things worse: stress, poor sleep, illness, even changes in weather sometimes.
Okay, so we know what to look for. How do we move towards making a confident diagnosis then? What are the actual criteria we should be using?
The key thing now is that modern criteria focus much more on self-reported symptoms and making a positive diagnosis rather than relying on things like tender point counts, which aren't really used diagnostically anymore.
Right, tender points are out. So what are the current criteria?
The main ones are the American College of Rheumatology, ACR, criteria from 2010, revised in 2016. For primary care, the simplified version involves looking at that widespread pain index score, 0-19, and the symptom severity scale score, 0-12.
Okay, the WPI and SSS again?
Exactly. Plus, the symptoms need to have been present for at least 3 months. And importantly, you need to be satisfied that there isn't another disorder that would fully explain the pain and other symptoms.
So how do the scores combine for a diagnosis?
Right, the diagnosis is met if you have either a WPI score of 7 or more and an SSS score of 5 or more, or a WPI score between 3 and 6 and an SSS score of 9 or more.
Okay, WPI 07 and SSS 05, or WPI 3 to 6 and SSS 09, plus the 3 months duration.
Precisely. That's the core of it.
And how can we practically use this in a busy clinic?
Using printable WPI SS sheets can be really helpful. Some practices integrate them into their electronic records. Patients could even fill them out while waiting.
Good idea.
And consider rescoring at follow-ups to track progress. While you need to be mindful of differentials, don't delay the diagnosis unnecessarily once the criteria are met and red flags are excluded.
Any key takeaways on making the diagnosis?
I think the main thing is that making a positive diagnosis is often incredibly validating for patients. It reduces that diagnostic uncertainty and anxiety.
Yeah.
And using those structured tools, the WPI SSS, helps legitimize the diagnosis, both for the patient and in the medical record. It moves it away from being purely subjective.
Definitely. But of course, with any diagnosis, especially one based on symptoms, we need to consider other possibilities. What are the key differential diagnoses for fibromyalgia?
Absolutely. There's overlap with many conditions. The goal isn't to rule out everything under the sun, but to consider and exclude serious or treatable alternatives where clinically indicated.
Right. So what are the main mimics we should have in mind?
Key ones include hypothyroidism, check TSH, polymyalgia rheumatica, usually older patients, shoulder-hip girdle pain, raised ESR-CRP, rheumatoid arthritis to look for joint swelling, check R-fanti-CCP if suspicious, lupus, SLE, often other features like rash, check ANA if suspected. MECFS, the defining feature there is post-exertional malaise, which is distinct. Sleep apnea, consider if daytime sleepiness is extreme, snoring, obesity, vitamin D or B12, deficiency, easy blood tests. And sometimes neuropathic pain syndromes, but the pattern of pain is usually different, more nerve distribution specific.
That's a useful list. What initial screening bloods would you generally recommend then?
A reasonable baseline screen would usually be FBC, UNEs, LFTs, TSH, maybe vitamin D and B12. CRP or ESR can be useful if you suspect inflammation. Maybe HbA1c depending on clinical picture.
Right.
But reserve things like ANA or RF for when you have a specific clinical suspicion based on history or exam. The key is, once you've ruled out obvious mimics and red flags, avoid excessive investigation.
And remind us, what are those key red flags that should make us pause and investigate further?
Things like unexplained significant weight loss, persistent fevers or night sweats, new onset of definite joint swelling, objective neurological signs like weakness, or focal bone pain. Those need looking into urgently.
Got it. Any final clinical pearls on differentials?
Yeah, just to reiterate, forget tender points for diagnosis. Also, remember, fibromyalgia can, and often does, coexist with other conditions like arthritis or thyroid issues.
Right, it's not always either.
Exactly. And always explain your thinking to the patient, why you think it is fibromyalgia and why you think it isn't something else. It builds trust.
Okay, brilliant. So we understand it, we can spot it, we can diagnose it, we've considered alternatives. Now, the crucial part, management. What can we actually do to help?
Right. Management needs to be multimodal and really patient-centered. The focus is less on a cure and more on improving function and managing symptoms. It's that biopsychosocial approach again.
Okay, so what are the main pillars of that approach?
You can think of it in terms of education and support, really strong evidence for this. Physical activity, moderate to strong evidence. Psychological support, also good evidence. Then pharmacological options, more limited, targeted role. And finally, multidisciplinary input when needed.
Let's start with the non-drug approaches. These seem key.
Absolutely, they're first line. Education and validation are critical. Explain what fibromyalgia is, that nociplastic pain model. Reassure them it's real, it's not degenerative. Use analogies like the volume control turned up.
Yeah,
Just feeling understood and believed can be therapeutic in itself.
that makes so much sense. What about physical activity?
This has some of the best evidence. Graded aerobic exercise, things like walking, swimming, cycling, yoga, tai chi. The key is starting low, going slow, and being regular.
Graded exercise.
Yes. Pacing is vital. Referring to physio or an exercise referral scheme can be really helpful for getting tailored advice on pacing and gradual progression.
And psychological therapies.
Also very important. Things like cognitive behavioral therapy, CBT, acceptance and commitment therapy, ACT, mindfulness-based approaches. They help patients develop coping strategies for pain, fatigue, mood. There are good online resources too. NHS Inform, SilverCloud, apps like Headspace. Some areas have pain management programs which offer intensive group-based input.
Okay, so education, exercise, psychological support are the foundation. What about medications? When do they fit in?
Medications aren't usually first line, but they can have a role for specific symptoms. Amitriptyline, low dose at night, can help with sleep and pain.
Right, amitriptyline is common.
Duloxetine, an SNRI, can be good if there's significant coexisting depression or anxiety alongside the pain. Pregabalin might be tried for neuropathic type pain, but, evidence is a bit mixed, and you need to be cautious about side effects and dependence.
Okay.
Paracetamol might offer some background relief. But crucially, NSAIDs and opioids are generally not recommended. They don't work well for this type of central pain, and the risks often outweigh benefits. NICE guidance is very clear on avoiding opioids.
That's a really important point about opioids and NSAIDs. What about wider team support?
Yeah, involving others can be key. Pain management clinics for complex cases. Occupational therapists are fantastic for fatigue management, pacing, adapting daily activities, work adjustments. And don't forget social support, helping patients access benefits if needed, like PIP or Blue Badge, providing supporting letters. Connecting them with patient support groups can also be really valuable.
It really sounds like a holistic approach is needed. Any practical tools or follow-up strategies for GPs?
Simple things help. Symptom diaries can help patients identify patterns and triggers, setting SMART goals for activity or self-management.
Yeah, SMART goals, yeah.
Regular follow-up is key. Maybe every 3 to 6 months initially, just to check in, review progress, offer support, adjust things if needed, provide links to good patient info. Versus Arthritis, NHS Inform have great leaflets.
Any final pearls on management?
I think it comes back to validation. Patients who feel believed and informed are much more likely to engage with self-management. Emphasize the multimodal approach. It's rarely just one thing. Empower them, build their self-efficacy. And those regular reviews really show you're there for the long haul.
Okay, so we manage most cases in primary care. But when should we think about referral? When is escalation needed?
Most patients can be managed well in primary care, but referrals are appropriate sometimes. Key reasons would be significant diagnostic uncertainty that persists despite your assessment, or if symptoms are really severe and resistant to the treatments you've tried over a decent period, or if there are significant comorbidities, physical or mental, that need specialist input.
Okay, so which specialties might we refer to and why?
Rheumatology, if there are atypical features, red flags, definite joint swelling, or maybe positive autoantibodies like ANA or RF that need interpretation. Pain management clinic, for persistent severe pain, maybe complex medication issues, or if they'd benefit from that intensive MDT approach. Physiotherapy, obviously, for tailored exercise, pacing advice.
Right.
Psychology or psychiatry, if there's severe comorbid mental health stuff, resistant depression, anxiety, PTSD. Maybe a sleep clinic if you strongly suspect something like sleep apnea.
Okay.
Occupational therapy for functional issues, fatigue management, work support, and benefits advisors or occupational health if work has been significantly impacted.
And thinking about Scotland again, are there specific pathways or services GPs should know about?
Yeah, it does vary between health boards. Some areas have community pain teams, specific fibromyalgia groups, Differing access to pain management programs, best bet is to check your local referral guidance. SCI Gateway usually has the up-to-date info for your area.
Good tip. And when should we generally avoid referring?
If the patient clearly meets the criteria, there are no red flags, and they haven't yet had a proper trial of the core primary care management strategies we've discussed. Avoid reflex referrals to rheumatology for classic fibromyalgia. It can delay appropriate management.
Right. How can we communicate that effectively to patients who might expect a specialist referral?
You could explain something like, based on your symptoms fitting the pattern of fibromyalgia and having checked for other causes, the best approach starts here in primary care. We understand this involves changes in pain processing, and the evidence shows that education, exercise, and coping strategies are the most effective first steps. We can manage this together.
That sounds reasonable. Any last thoughts on referrals?
Just discuss the reason for referral clearly. Frame it as accessing specific support or therapy, not just more tests. Make it collaborative.
Absolutely. Now, fibromyalgia obviously impacts people deeply. Let's talk about the human side, the psychosocial aspects.
Yes, this is so important. It really sits at that crossroads of physical, psychological, and social factors. Addressing this is vital for effective care and for building that therapeutic relationship.
How does it typically impact people beyond the physical symptoms?
Hugely. Emotionally, there's often frustration, feeling invalidated, fear about the future. Mental health-wise, we see high rates of anxiety, depression, sometimes PTSD, health anxiety. Socially, relationships can be strained. People become isolated because they can't participate like they used to. Occupationally, it can affect work, lead to job loss, financial stress, and sadly, some have negative experiences with healthcare itself, feeling dismissed or passed around.
That sounds incredibly tough. You mentioned stigma earlier. How does that play out?
Unfortunately, many patients hear dismissive comments or feel disbelieved because it's an invisible illness. Their suffering isn't obvious.
Yeah.
This is why GP empathy, active listening, consistent messaging that fibromyalgia is a real condition is so crucial. It combats that stigma and helps patients feel validated.
Are there specific communication tips or phrases GPs can use?
Yes, small shifts help. Instead of your tests are normal, maybe your tests haven't shown inflammation, but your symptoms point strongly to fibromyalgia, a condition of altered pain processing.
Okay.
If they feel disbelieved, say, I hear how difficult this has been and I believe what you're telling me. When discussing management, focus on collaboration. Let's work together on strategies rather than you need to try harder.
Those are powerful examples. What about the Scottish context again? Any specific social factors?
Yes, things like deprivation, social isolation, especially in rural areas with access challenges, can definitely worsen the experience. Adverse childhood experiences, ACEs, are also linked to chronic pain, so being mindful of potential trauma history sensitively can be relevant.
So what practical things can GPs do in primary care to support these psychosocial aspects?
Continuity of care helps build trust. Use empowering language. Involve patients in decisions. What are your thoughts on this? Set a joint agenda. What's most important for you today? Connect them to community resources, social prescribing link workers, support groups. Help navigate practicalities like sick notes, benefits applications, PIP, etc., occupational health liaisons. These things make a huge difference.
Okay. Research is always moving. What about the latest evidence or controversies GPs should be aware of?
Well, that concept of nociplastic pain continues to be refined and emphasized. It's changing how we explain the condition to patients, less about muscles, more about the nervous system.
Right. What about treatments patients might ask about, like LDN or cannabis?
Low-dose naltrexone, LDN. Some small studies suggest potential benefit, possibly via anti-inflammatory effects in the CNS. But Nice Sign don't routinely recommend it due to lack of large trials. It's not widely available on NHS prescription in Scotland for this. If used off-label, requires very careful discussion and documentation.
Okay. Caution with LDN and medical cannabis.
Nice specifically advises against cannabinoids for chronic primary pain, including fibromyalgia, due to insufficient evidence and potential risks. Scottish pain clinics generally don't prescribe it either, so acknowledge patient interest, but explain the evidence limitations clearly.
What about complementary therapies like acupuncture or Tai Chi?
Evidence is often limited or mixed for long-term benefit, but some patients find them helpful adjuncts for short-term relief, relaxation, mood. If they're safe and affordable for the patient, it's reasonable to support them alongside core treatments, but not as replacements.
And any recent guideline updates to highlight?
Recent guidelines from NICE-CKS, Cochrane, EULAR, etc. continue to strongly emphasize non-drug approaches first exercise, CBT. And they consistently warn against routine opioid use. Worth keeping updated with these.
Okay. To really bring this together, maybe we could run through a couple of brief case
A
examples.
good idea. Let's take Sarah, 42, teacher. Presents with widespread pain, fatigue, concentration issues for over a year. Blood's normal. Meets ACR criteria, WPI SSS scores are high.
Right.
Management focuses on education about nociplastic pain, physio referral for graded exercise, low-impact aerobic, signposting to online CBT for pain fatigue management. Key point. Consider fibro even with normal tests. Use multimodal non-drug approach first.
Okay, good example. Another one.
David, 58, retired engineer. Widespread pain, poor sleep, low mood. Has hypertension. Meets criteria. Management. Low-dose amitriptyline at night for sleep pain. Encourage joining a local walking group. Gentle activity. Mindfulness resources online. Key point here. Address the coexisting low mood. Explain the link between pain and mood.
Makes sense. And one more.
Maria, 35, healthcare worker. History of significant early life stress. Widespread pain, fatigue, IBS, anxiety. Meets criteria. Management. Focus on building trust, validation. Referral to social prescribing link worker for stress reduction activities. Support groups. Info on trauma-informed approaches. Gentle yoga encouraged. Key point. Consider the wider psychosocial context, trauma history, value of community support.
Those cases really illustrate the different facets. So to wrap up our deep dive, could you summarize the absolute key takeaways for GPs managing fibromyalgia?
Okay. Remember, fibromyalgia is common, chronic, involves altered central pain processing. Use the ACR criteria to rule in the diagnosis confidently once red flags mimics are excluded. Prioritize non-drug management, education, validation, graded exercise, psychological support, CBT, mindfulness. Use meds like amitriptyline or duloxetine targetedly for specific symptoms. Strongly avoid opioids and SIDs. Communicate empathetically, validate their experience, involve them in planning. Consider psychosocial factors, especially in contexts like Scotland with known inequalities. Follow up regularly. And maybe the biggest takeaway, believing your patient and partnering with them is often the most powerful intervention you have.
We really hope this deep dive has armed you, the GP, with clearer understanding and practical strategies for fibromyalgia.
Absolutely. Remember, early recognition and that holistic supportive approach can make a huge difference to your patients' lives.
We do encourage you to check out the resources like NICE-CKS and NHS Inform for more detailed guidance.
And we'd love to hear from you. What are your experiences? What works well? What challenges remain? Please join the conversation online with your insights and questions.
Thank you so much for joining us for this deep dive. We look forward to exploring another important primary care topic with you next time.